The Auditor-General provides assurance to Parliament on the accountability and performance of the Victorian public sector. The Auditor-General conducts financial audits and performance audits and reports on the results of these audits to Parliament. On 28 November 2013, the Auditor-General tabled his performance audit report on occupational health and safety risk in public hospitals. This presentation is a summary of the report on occupational health and safety risk in public hospitals. To read the full report, go to our website at www.audit.vic.gov.au. The summary will cover the background and rationale for the audit, objective and scope of the audit, methodology used, conclusion and key findings, evidence of the audit's impact during the audit itself, and the recommendations based on the evidence collected. The community expects that patient safety and well-being will be paramount in public hospitals because that's what hospitals do, look after patients. The safety of staff working in public hospitals is not always given the same attention or priority, yet the safety of staff in the workplace is as important as patient safety. Occupational Health and Safety, or OHS, covers employer health, safety and welfare in the workplace. Occupational health and safety is particularly important in public hospitals. This is because hospitals are hazardous environments. For example, staff may be exposed to infections or chemical agents. They may injure themselves lifting or moving patients. Slips, trips and falls can occur, and staff may suffer verbal and/or physical abuse. The media have reported on the growing incidence of violence against staff in emergency departments. These kinds of hazards can lead to stress and serious injury, and potentially even death. Occupational health and safety is also costly. The work cover premium paid by Victorian public hospitals is substantial, with over $80 million paid in 2012-13 alone. Occupational health and safety in public hospitals is a large concern, with nearly 100,000 workers in Victoria. It is the single largest workforce in the public sector. Despite the level and scale of risk, there have been few reviews of occupational health and safety in public hospitals in Victoria or Australia. Given its importance, the Victorian Auditor-General's Office wanted to find out how well OHS risk was being managed in Victorian public hospitals. The main focus was on the employer. Under the OHS Act 2004, it is the employer who is responsible for workers' safety. Under the devolved health model in Victoria, this means it is the boards of health services and hospitals that are responsible for making sure that staff in public hospitals are not exposed to risk. We looked at 4 health services, 2 large metropolitan services, 1 large regional service, and 1 small hospital in regional Victoria. In selecting the 4 work sites, we aim to capture a range of environments and experiences and a range of work cover claims to full-time equivalent data. The Auditor-General also examined the roles of the Department of Health and WorkSafe. The department is the manager of the health system in Victoria and is responsible for monitoring the performance of public hospitals. WorkSafe is the regulator. It has statutory obligations to help reduce OHS risks and injuries. We reviewed extensive documentation from the department and WorkSafe, including claims, premium data, and project management over the past 5 years. We also examined documents provided by the 4 health services, including policy and procedures and risk management records. We reviewed recent literature on occupational health and safety in health and other industries to benchmark good practice. In addition to interviews with the relevant staff in the department and WorkSafe, we interviewed 24 managers of work units in high-risk settings in the 4 health services and 42 staff in these high-risk settings. We covered staff working in emergency departments, mental health, aged care and environmental services. The audit team surveyed 11 of the 12 major metropolitan hospitals and 5 large regional public hospitals to collect baseline data on how key OHS elements are being managed. Elements that were looked at included workplace injuries, training, dedicated OHS resources, and accountability. The audit team also administered a safety climate survey to employees in the 4 audited hospitals. The survey sought perceptions of management commitment to OHS, safety culture in the workplace, personal appreciation of risk, and insights into the nature of the work environment from an OHS perspective. Over 3,300 responses were received from a range of occupations. The audit found that public hospital staff are being put at unnecessary risk while at work. This is because the safety management systems in public hospitals are generally not systematic, integrated, or comprehensive. The Department of Health, as the health system manager, doesn't monitor sector-wide OHS risks or emerging trends in public hospitals. WorkSafe, as the regulator, doesn't know if its project activity reduces OHS risk. The audit found insufficient priority and accountability for OHS in public hospitals. Information on OHS incidents and risks is incomplete, meaning that hospital management is not fully informed of OHS risk. A number of factors contributed to these findings. A culture in public hospitals of accepting risks, inadequate information about OHS is given to staff, insufficient training is provided to staff and managers, and unit managers with responsibility for OHS need to be held to account. For example, it is not enough to have OHS responsibilities listed in position descriptions. There needs to be targets and mechanisms to hold these managers to account. The audits found that some unit managers did not know what their OHS responsibilities involved. And even though the Department of Health is the health system manager, it doesn't require public hospital management to provide assurance that staff are adequately protected from OHS risk. Most serious of all, the audit found fundamental weaknesses in the information reporting system used in public hospitals. It is not fit for purpose because it has been designed to capture clinical risks affecting patient safety, not staff safety. This means there are some mandatory fields which are irrelevant because they relate to the reporting of clinical incidents. It also means there are no fields to capture vital OHS information such as the signs and triggers leading to frequent occupational violence incidents, for example assaults. Categories to classify OHS incidents are complicated, unclear, and too numerous. For example, occupational violence can be classified as inappropriate conduct or physical aggression. Such inconsistency means that incident information cannot readily inform management or lead to improvements. It can take a staff member 20 to 25 minutes to complete an incident report in the system. Some staff might need to wait until after their shift to file a report. Others might need to wait for a computer to become available. A consistent finding was that OHS incidents are underreported. For example, code blacks are called in public hospitals when staff are physically threatened. These are recorded in a security log. In one hospital, comparison between the code black incidents recorded and the incidents recorded in the risk management system found that 70% of incidents where staff were physically threatened and a code black was called were not reported in the incident reporting system. Reporting was also not timely. This means that staff might be exposed to an OHS risk several times before management is aware of and acts on the hazard. Another weakness in the information collected relates to the safety inspections carried out in public hospitals. In the audited hospitals, safety inspections varied in frequency, for example, twice a year as opposed to monthly, and in types of risks examined. For example, some hospitals might not include radiation as a risk and others will. The audit found little evidence of analysis of the factors that cause OHS problems or the effectiveness of the controls put in place. Nothing seems to be done with the information collected. It should be noted that the Department of Health has budgeted for changes to the incident reporting system. However, radical change is needed, and at the time of the audit, it was not clear how such change could occur. Other key findings relate to sector-wide identification of risk. The audit found that neither the Department of Health nor WorkSafe have a comprehensive understanding of sector-wide risk because they don't monitor this. Yet, without sector-wide understanding, it is difficult for the department to respond appropriately to emerging issues or to assist boards to respond. The exact role of the department in worker health and safety is not clear. WorkSafe cannot provide this sector-wide snapshot of emerging trends either, as it is only notified of serious injuries or when claims are made. So it is not really in a position to monitor OHS risks, which do not result in injury. There are also practical limits to WorkSafe's ability to monitor all incident data across so many Victorian worksites and industries. The audit found that WorkSafe did not know if its 18 projects targeting public hospital worksites between 2007 and 2012 have been effective in reducing OHS risk. Selection of hospital sites was not based on clear criteria. For example, hospitals with a higher standard claim rate per full-time equivalent staff did not consistently receive a greater number of visits than hospitals with lower claim rates. Most projects did not have clear objectives, and even when they did, WorkSafe did not measure progress against the objectives. There was no evidence of robust evaluation, and even if projects were effective, there was no way of identifying improvements and incorporating these into WorkSafe's operations. Usually, the impact of an audit does not become apparent until sometime after the audit has been completed. However, in this audit, there was evidence of impact during the audit itself. For example, WorkSafe recognized that it needs to have a better model for targeting and reducing OHS risk. WorkSafe has developed a new model for targeting risk in all industries, with an ongoing program focus on the top OHS risks, rather than having shorter discrete projects. The department and WorkSafe have had little collaboration in recent years, but during the course of the audit met regularly and demonstrated a willingness to maintain the momentum of this more collaborative approach into the future. There is tangible evidence already of OHS being more embedded in the training that is provided for board members. For example, the Building Board Capability Advisory Committee has now incorporated OHS and the learning from the current audit into OHS risk in public hospitals into its approach to building board capability in 2014. There are 7 recommendations, all accepted by the department and WorkSafe. Recommendation 1. That public hospitals and health services give high priority to and ensure accountability for the management of OHS. Recommendation 2. That the Department of Health requires public hospitals and health services to annually assure it that they manage OHS through a systematic approach in accordance with relevant legislation and standards, and provide workers with the highest level of protection against risks to their health and safety that is reasonably practical in the circumstances. Recommendation 3. That WorkSafe provides support to the boards of public hospitals and health services on OHS leadership and requirements to raise awareness of their responsibilities to comply with OHS laws so that public hospital staff receive the highest practicable level of OHS protection. Recommendation 4. That public hospitals and health services implement a systematic and integrated approach to OHS that complies with the Australian Standard on OHS Management Systems, AS 4801, or an equivalent standard. Recommendation 5. That while public hospital industry OHS risk remains significant compared to other industries, WorkSafe annually confirms to the Department of Health that public hospitals and health services comply with OHS legislation, have in place a systematic approach to the control of OHS risks, and that effective risk control mechanisms exist. Recommendation 6. That WorkSafe identifies sector-wide OHS risks in public hospitals and provides this information to the Department of Health, public hospitals and health services. Recommendation 7. That the Department of Health and WorkSafe collaborate to assist public hospitals and health services to control the highest OHS risks. All our reports are available on our website. If you have any questions about this or other reports, or if you have anything else you would like to discuss with us, including ideas for future audit topics, please call us on 03 8601 7000 or contact us via our website.